Okay, welcome back, everyone. Dr. Linder here. Let's take a look. We are still looking at the axial skeleton, but now we're going to be focusing on the vertebral column. So when we look at the vertebral column, we can see that in this illustration here, we have the individual looking this way, right? And we can see that we have 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and then we have the sacrum and the coccyx down at the bottom. Now, the curvature of the spine, we have the thoracic curve, which is considered to be the primary curve. This is the curve that we're born with, right? You're in your mother's womb, you have this fetal arc, this fetal curvature, and then over time, we develop these secondary curves, and the cervical curve is called a lordosis, and the lumbar curve is called a lordosis. And this lordotic curvature happens when a baby is crawling and their head looks up. We start to form this cervical curve, the cervical lordosis. As a baby is crawling, their belly hangs down, and that helps create the lumbar lordosis. The thoracic curvature is called a kyphosis with a K, a kyphosis. Now, sometimes with these curvatures, we will hear the term hyperlordosis, hyperkyphosis, or we'll hear the term hypolordosis or hypokyphosis. The term hypo means less than, and hyper means more than. So when we hear of a hypolordosis of the cervical spine, it means that there's less of a cervical curve. When we hear the term hyperlordosis of the lumbar spine, it means that there is an increased lumbar lordosis of the lumbar spine. When we hear the term hyperkyphosis, it means that there's more of a thoracic curvature, a thoracic kyphotic curve. When you hear hypokyphosis, it means that there's less of a curvature. So again, we have 7 cervical vertebrae, 12 thoracic, 5 lumbar. So altogether, we have 24 freely movable vertebrae. Here's what it looks like on a real spine. You see 7 cervicals, 12 thoracic, 5 lumbar. We see a cervical lordosis, a thoracic kyphosis, and a lumbar lordosis once again. In between each vertebrae, we should have intervertebral discs, IVDs, intervertebral discs. Except we don't have a disc between C1 and C2. There's no disc between atlas and axis. And here's what a disc looks like. So in the center of it, we have something called the nucleus pulposus. And on the outer portion, we have these annular fibers called the annular fibrosis. And the annular fibrosis is highly innervated. There's lots of nerves that go to the annular fibers, and that's what makes it painful when a disc starts to bulge. If it starts to break through these annular fibers, it becomes painful. Sometimes it can break all the way through here, and sometimes it can even separate. That becomes a problem, especially if it's separated and part of the disc fragment is actually sitting on a nerve. That becomes extremely painful, and you can get wasting away of muscles if that happens. Okay, so let's look at some of the features of a typical vertebrae. So this is a typical vertebrae from a superior view. We're looking at it from above down. This is anterior in the front, and back here is posterior. So you have to be able to orient yourself. Here is a foramen. That's called the vertebral foramen. What do you think travels through the vertebral foramen? That's going to be the spinal cord. The spinal cord is going to travel through there. So in the front, we have a vertebral body, And what do you think is going to sit on the vertebral body is going to be the intervertebral disc, right? So this structure here, the intervertebral disc, is going to be sitting on the vertebral body. And here's your spinal cord sitting in the vertebral foramen. There's going to be nerves that come out this way. So now when a disc starts to bulge or herniate, it can push up against the nerve, ouch, or it can push back and hit spinal cord, also ouch. Okay. Okay, we have, let me remove, let's erase this. Okay. We have, again, the vertebral body. Off the body, we're going to have pedicles. And then we're going to have lamina. These lamina are important because when those lamina fuse, when they come together, it's going to form this structure here called the spinous process. Okay, and if you ever hear of a surgical procedure called a laminectomy, they're cutting this away so that there's room when people have like a herniated disc and the disc is pushing back against the spinal cord, it creates compression. Well, if they remove everything back here, it allows and gives expansion of that spinal cord to remove the pressure. Let's look at it from the lateral view. Again, here's the vertebral body. Right here is the pedicle. And then here's the spinous process down here. Through this hole, we're going to have nerves that come out of it. Okay. It's called the intervertebral foramen. The intervertebral foramen. All right, still, let's look at, again, superior view, looking down. Remember, here is the vertebral body. Here are the pedicles. Here's the vertebral foramen. This is a superior articulating process. Now, if there's a superior articulating process, there has to be an inferior articulating process. And there is, we just can't see it because we're looking at it from above. You have to look at it from the underneath to actually see it. So there's an superior articulating process, and associated to the process is going to be a facet, a superior articulating facet. Here's the other superior articulating process, but right there is the superior articulating facet. Here's the spinous process, and here's the transverse process. Transverse process is transverse. It runs across. And here's the spinous process. Again, here's the lamina, and here's another lamina. When those laminas fuse, they actually form the spinous process. Okay, from the lateral view, here's that superior articulating process. And this is the superior articulating facet. Well, what do you think the superior articulating facet is going to articulate with? It's going to articulate with the vertebrae above it. And it's going to have its own facet that's going to attach here. It's just called the inferior articulating facet. So what we have happening is we're going to have the superior articulating process and facet of one bone is going to articulate with the inferior articulating process and facet of another bone to create a joint. Okay. Here is the transverse process from the side, and here's the spinous process from the side. Here's the inferior articulating process. And right around there is going to be the facet, the inferior articulating facet. Let's look at cervical vertebrae. Now, there are 7 bones in the neck: C1, C2, C3, C4, C5, C6, C7. And look, right here is a joint. So we have the superior articulating facet of C3. And here is the inferior articulating facet of C2. And they form a nice joint. Okay. Notice that C7 has a very distinct spinous process. It's the most prominent one. It's the one that's going to stick out the most. So they call it the vertebral prominence because it's the most prominent spinous process of the cervical spine. When we look at some of the unique features of a cervical vertebrae, and again, it's a superior view, we still have a vertebral body, we still have a vertebral foramen, we have a transverse process. But what's unique about the cervical vertebrae that no other vertebrae have in the spinal column is this hole found in the transverse process. The hole that's found within the transverse process is called the transverse foramen. Very important structure because the vertebral artery is going to travel through the transverse foramen. The vertebral artery comes off the heart and feeds blood, oxygen, and glucose into the brain. The other unique feature is if you look at the spinous process of the cervical vertebrae, we call it bifid. There's like a fork in the road. It's bifid. It's a bifid spinous process. It's the only vertebrae within the spinal column that have it. So if you are asked on an exam, what type of vertebrae is it? You got to look at some of these features. If you see a bifid spinous, it can't be a thoracic vertebrae and it can't be a lumbar. Bifid spinuses are only found in the cervical region. And again, here are the two lamina. Laminas come together to form the spinous process. Here are the pedicles. Pedicles come off the vertebral body. Okay. Now, this vertebrae is unique. It is atypical. The top two bones, which are C1 and C2, again, C1 is the atlas and C2 is the axis. These are atypical, meaning all of the bony landmarks that we went over here are not really found. These are typical vertebrae, have all these unique, landmarks. But when we talk about C1, they don't have the vertebral body, okay? And they don't have the spinous processes. So they're atypical. We call them atypical. So what they have, instead of a spinous process, there's a posterior arch and there's a posterior tubercle, right? That would be equivalent to like the lamina, like the posterior arch would be like the lamina, and the posterior tubercle would be like the spinous process. Okay, but we don't have lamina, we don't have a spinous process of C1. Okay, this is the atlas. We're looking at the atlas here. So there is a posterior arch and there's going to be an anterior arch. There's a posterior tubercle and there's an anterior tubercle. The atlas does have very wide and long transverse processes. It's the longest of the entire cervical spine. Here is the superior articulating process with the superior articulating facet. This superior articulating facet of the atlas is going to articulate with the occipital condyles of the skull. Remember, the occipital condyles are of the occiput, and that attaches here. It's going to create that nodding mechanism, not when you say yes, but when you just nod yes. Okay. And then there is a vertebral foramen, and that's where the medulla oblongata is going to travel down. Here is the transverse foramen. The transverse foramen is that hole, the two holes that travel through the transverse process, and that's for the vertebral artery to travel through. Okay. Now, here is C2, which is axis. And there's a big difference between atlas and axis. The axis does have a vertebral body, and off the vertebral body is this projection called the dens, also known as the odontoid process, which from this view, here is the atlas, C1, and here's the axis, and C2 has this bony prominence sticking up that comes off the vertebral body, which is here of C2. And you can see C2 does have a bifid spinous process, but C1 has this posterior arch and it has an anterior arch. Okay. And what holds C1 and C2 together is this transverse ligament going around in this direction. So this allows your atlas to rotate on its axis, right? Axis is for rotation, but it's the atlas, the top bone, C1, that's actually rotating when you shake your head no. It's rotating around the dens or the odontoid process of the axis. So this is the bird's eye view looking down. You can't quite see it, but this is the dens that's projecting upward at us. C2 does have a lamina, and C2 does have a spinous process that's bifid, and it does have a vertebral canal. But remember, there is no disc between C1 and C2. You don't see a disc there because you need two vertebral bodies above and below to have a disc, and there's no vertebral body of atlas. Okay, let's just make sure we covered everything here. Here's the superior articulating facet. This is going to articulate with C1. Here's the TP, the transverse process. And then here's the transverse foramen going through the transverse process. And again, that's for the vertebral artery. Here is the superior articulating facet of atlas. That's going to be the articulation for the occipital condyles. Okay, so there's your cervical curve. That's your lordosis, C1 through C7. We see that C7 has the vertebral prominens, the most prominent spinous process. Let's look at the thoracic vertebrae. Thoracic vertebrae is T1 to T12. That's our kyphosis. And there's your intervertebral foramen. This is the hole that is formed when you have the superior articulating facet joining with the inferior articulating facet, and they create a hole called the intervertebral foramen. And what's going to travel from those holes are going to be nerves. And these nerves, some nerves go to your heart, and some nerves are going to go to the lungs, and some nerves are going to go to muscle. And when you have these nerves that get pinched, they call it a subluxation. Not a medical subluxation, because a medical subluxation is when there's actually a dislocation of a vertebrae. But a vertebral subluxation has a neurological component to it. It has a myological component to it. It has an inflammatory component to it. It has a kinesiological component. So when you have a neurological component, you can have muscle wasting or you can have organ dysfunction. When you have kinesiological dysfunction, you get abnormal movement or painful movement. When you have histological component, there's inflammation that's associated with it. Okay, so there's different, when you have a myological component, you get muscle spasms, right? Your muscles go into a spasm to protect the area, especially if a disc is inflamed or a nerve is being pinched. So with a vertebral subluxation, there is not just perhaps a slight misalignment, but you have neurological compromise with it. Okay, so we have 12 thoracic vertebrae. When we look at the thoracic vertebrae, again, we can see it's typical vertebrae. So there is a vertebral body, a vertebral foramen. We have your transverse process. We have a spinous process. Notice the spinous is not bifid here. We do have pedicles. We do have lamina. We have a superior articulating process with a superior articulating facet. And what's unique about the thoracic vertebrae is that we have a facet close to the vertebral body, and we have another facet near the transverse process. So this is the transverse costal facet, and then we have a superior costal facet off the vertebral body. Now, these facets are going to be for, what do you think is going to join here? You're going to have ribs that attach. There's going to be ribs that articulate with the vertebral body and the transverse process. So the ribs have to have a facet. So there's 12 thoracic vertebrae and there's 12 pairs of ribs as well. Let's look at these facets from the side view. So here's the vertebral body. So this is anterior. Here's the spinous process. This is posterior. Here's the transverse process. Off the transverse process is a costal facet. Off the vertebral body, there is a superior costal facet, and there's going to be an inferior costal facet. And this is where the ribs are going to articulate. Articulate with what? Well, here's the rib. We have a head of a rib. We have a neck of a rib. We have an angle of a rib. We have a tubercle of the rib. So all of these are going to be little attachment sites for these ribs. You can see here from this view, here's the vertebral body. And look, here's the head of the rib. Here's the neck. And here's the tubercle of the rib. And they're all making contact with those facets. Okay, here's the transverse costal facet. That's what we see here, the transverse costal facet. Here's the costal facet. It's either the superior or inferior on this side. Okay, let's look at the lumbar vertebrae. And there's 5, L1 to L5. Now, when we look at the lumbar vertebrae, they are the largest. They have the largest, thickest, heaviest vertebral body. They have distinct transverse processes, but they have short, knobby spinous processes. And one of the unique features, let's see if I can show it to you here. We know that the cervical vertebrae, these are bifid spinous. The spinous processes of the thoracic, they angle down. Okay, if I can show you from here, see how the spinous looks like a nose, how it kind of has this inferior angulation. All the thoracic vertebrae have spinuses that go down, but their transverse processes angle up. So they move in these opposite directions. The thoracic spinuses move upward, whereas the spinuses angle downward. So those features tell you it's a thoracic vertebrae. But when we look at a lumbar vertebrae, these are short, knobby spinous processes, but the vertebral bodies are pretty thick and large in relationship. Okay, we do have lamina, we do have pedicles, we have a superior articulating process, and on the inside here is going to be the superior articulating facets. And you got the vertebral foramen. Oftentimes, you'll hear on MRI reports this term called stenosis. Now, if you've ever seen, typically you'll see it in older people where when they walk, they have this slight forward bend at their trunk. They're bending and walking forward because they have something called spinal stenosis, which is narrowing of the vertebral foramen. And when they bend forward, they get relief of pressure. When they stand up tall, they get pain in their lower back and in their legs. So this kink or this bending at the hip, when they walk forward with this forward antalgic lean, it takes a lot of pressure off their lumbar spine. We see it with something called spinal stenosis, which is when the spinal cord is being compressed in the vertebral foramen. Either these ligaments that you have lining the vertebral foramen are thicker and hypertrophied and inflamed, compressing the spinal cord, or there's just so many gross arthritic bony changes that are compressing the spinal cord, or you can have a herniated disc that's been chronic and so bad, pushing back, compressing the spinal cord. All of those create a condition called spinal stenosis. Again, there's the short knobby spinous process. Here's your transverse process. You have your superior articulating process and an inferior articulating process. And don't forget, on each of those, you're going to have your inferior articulating facet, and then you're going to have your superior articulating facet. The facets are just the smooth surface in which joints are going to form. And then this hole here and this hole here is going to be formed, creating these holes here, which is where the nerves come out. They're called the intervertebral foramen. So let's not confuse intervertebral foramen with vertebral foramen. Intervertebral foramen is for the nerve roots to exit, but the vertebral foramen is where the spinal cord travels. Now, having nice open intervertebral foramen is dependent on how healthy these discs are. Because if the discs are nice and thick, then the hole is nice and open. If you have compression and degeneration of the discs, then the gap or the space between two vertebrae are going to become diminished, and they call it encroachment of the nerve, where the nerve gets pinched. Okay. So when we look at these, right, it's important to be able to distinguish which is a cervical, which is a thoracic, and which is a lumbar. So when we look at a cervical vertebrae, they have the bifid spinous. When we look at a lumbar vertebrae, they have the largest vertebral bodies, but they have the short knobby spinous processes. When we look at a thoracic vertebrae, the transverse processes angle up, whereas the spinous process is much long and slender, and they angle down. But the spinuses on a thoracic vertebrae are much, much longer than the spinous of a cervical vertebrae. Okay. Okay, let's look at the sacrum and the coccyx. So when we look at the sacrum, this is an anterior view. The sacral base is on the top, and then the apex is on the bottom, right? Typically, when you think of like a mountain, right, the apex is on the top and the base is on the bottom. Well, the base just means it's the widest part. So the widest part of the sacrum in this case is on the top, and the peak is at the bottom. That's the apex. We have holes in the sacrum. Those are called sacral foramina, and nerve roots exit there. We call this the S1 sacral foramina, S2, S3, S4, and nerve roots exit. Now, the spinal cord ends somewhere between the L1 and L2 interspace, right around there. L1, 2, 3, 4, L5. So between L1 and L2 interspace, that's where the spinal cord ends. And everything inferior to L2 is going to be spinal nerves. So what we're getting exiting through here are nerve roots, and that's it, S1 through S4. This portion up here is called the sacral ala. The sacral ala. The front most prominent part right in here is called the sacral promontory. These are transverse lines. And then down at the bottom, we have the coccyx. The coccyx is anywhere from 3 to 5 fused segments. When we look at the sacrum and the coccyx from the posterior view, we have the entrance to the sacral canal, which is here. That would be equivalent to the vertebral foramen, right? And then on the bottom, it's called the sacral hiatus. Sacral hiatus. We don't have spinous processes in the sacral spine. We have what's called the median sacral crest. That's here. That would be equivalent to like the spinous processes. And then there's a lateral sacral crest on both of these sides. From the lateral view, we can see that we have a sacral curvature and a coccygeal curvature. And you have to be careful when people fall. Typically, when you land on your rump, it's common for people to kind of dislocate or fracture the coccyx. Very, very painful. And there's lots of neurological implications there because part of the meninges actually attach to the coccyx. And when you land on the coccyx and this dislocates in this direction, it puts a tug or a complete meningeal tug on all of the meninges, and the meninges go around the spinal cord and the brain. That's why people get pounding headaches typically the next day after a slip and a fall and they land on their tush, okay? Here is the articulating surface. This is what is going to form what we call the SI joint. The SI joint stands for the sacroiliac joint. So part of the ilium, which we haven't done yet, we'll do that when we cover the lower extremity, is going to articulate with the sacrum, and we call it the sacroiliac joint or the SI joint. Okay, let's look at the thoracic component. Now, when we look at the thoracic spine, we'll see the sternum here in the center. And the sternum has a manubrium, it's got a body, and it has a xiphoid process. That's the sternum. Okay, manubrium is up here. This is the body, and the xiphoid is the point at the inferior end. What we're looking at are these 12 pairs of ribs. Ribs 1 through 7 are true because they have their own cartilage, right? Right here, this is its own separate and distinct cartilage. When they have a shared cartilage, which we see with ribs 8 through 12, it's false ribs. False ribs share cartilage. Then the floating ribs, ribs 11 and 12, have no cartilage at all. They just float. But all of them are going to attach to the thoracic vertebrae. So T1 vertebrae is linked with the T1 with the first rib. T2, second rib. T12, 12th rib. Okay, so true ribs 1 through 7 have their own cartilage that attaches to the sternum, and false ribs have shared cartilage with the sternum. Floating ribs 11 and 12, they don't have any cartilage at all. Okay, the upper part of the manubrium is called the jugular notch. The jugular notch is the most superior part. Okay, so right here, that depression is the jugular notch. This right here is a really important structure called the sternal angle or the angle of Louis. When we palpate this connection between the manubrium and the body, there's a little bump that we all have. And it's an important palpatory landmark in healthcare because that landmark takes us to the second rib. Why is that important? When you palpate this and you can palpate the second rib, this is the second intercostal space, third rib, third intercostal space, fourth rib, fourth intercostal space. It's important to count ribs and spaces because when you listen with a stethoscope, you don't want to put a stethoscope over a rib. You want to put it on the intercostal spaces to hear breathing sounds. You want to put the stethoscope over the intercostal spaces to hear heart valve closure. Okay, so once you find that sternal angle or the angle of Louis, that takes us to the second rib. And once you go inferior to it, it's the second intercostal space, third rib, third intercostal space, and all the way down. When you look at it from the posterior view, again, we can see the true ribs 1 through 7 and the false ribs 8 through 12. You can see the two floating ribs, rib 11 and rib 12. Notice how the thoracic vertebrae transverse processes, how they angle upward like that. The TPs angle up, and the spinuses we could see angle down like a nose. Okay, very important to see that. Again, we have the manubrium, the body, the xiphoid process, the sternal angle or the angle of Louis, that's this line that's always associated with the second rib. Here's the jugular notch, and here's the clavicular notch. The clavicular notch is where the clavicle articulates to form the sternoclavicular joint. The sternoclavicular joint. When we look at the ribs, we showed you this earlier, we can see that we have in the thoracic region, we have these facets. And those facets are needed for the ribs to articulate with. Okay, you have the neck, we have the head, here's your intervertebral disc, the vertebral bodies, okay? From the bird's eye view looking down, again, here's the head of the rib, here's the neck of the rib, here's the angle of the rib, and there's the tubercle of the rib. Here's your vertebral foramen, here's your vertebral body, these are your pedicles, here's your lamina, spinous process, transverse process, and here's the costal facet. Okay. When you look at the rib, again, from another view, here's the head, here's the neck, and here is the tubercle. Here's the angle, and these are articular facets. Okay,